Morning, everybody. Okay. So let's wait just a few moments till we have a few more folks and we'll get going. Everybody have a nice weekend. Toki, was it very busy? Can you guys hear me okay?
Yeah, I can hear you.
Yeah.
Good morning.
All right, I'll give it one more minute, 30 seconds and get going. Okay, so last week a request was made by Dr. Capon that we review some intracardiac stuff. And so, as they say, your wish is my command. So we'll go over some basics of invasive EP and go over a case that I did actually at this point quite a few years ago. Okay, so the first thing we always do when we do an EP study, of course, is look at the 12-lead electrocardiogram, because we want to make sure that we, see if there's any evidence for pre-excitation or what it is that we think we're dealing with here. And I think we would all agree, remember, of course, that this is at 100 paper speed. In the EP lab, we're routinely running the paper speed quite a bit faster than the usual 25 millimeters per second that we see on a routine standard electrocardiogram. And that's because we're looking for subtle differences and interval changes that are harder to measure at those faster paper speeds, or slower paper speeds, which compress things. So, but I think you would all agree that we see evidence of a delta wave in a very short PR interval, and we're going to discuss the pattern in just a moment and how we determined non-invasively that this is likely in the septal area and anteroseptal. But this is the catheters after we have gotten vascular access. So as you know, when we do an EP study, we typically put a minimum of 4 catheters in the heart, and these would be a catheter in the area of the bundle of His. In this case, we have a quadrupolar catheter. Some people will put a hexapolar with 3 pairs. Some will even put a decapolar and have it be so that they can really clearly identify all the inferior and superior aspects of the bundle of His. We have a catheter, in this case, in the coronary sinus, placed from above in the right IJ. But those of you who've done cases with Barry and others probably know that it can also be placed from the groin using a deflexible catheter, both very reasonable approaches. In this case, a decapolar catheter, allowing us to see the impulses on the left side of the heart, because remember that the coronary sinus sits behind the mitral annulus. So as Dr. Walsh says in his famous chapter in Natus's Pediatric Cardiology, the coronary sinus is God's gift to the electrophysiologist because it allows us a peephole into what's going on the left side of the heart without actually having to go into the left side of the heart. We have a catheter in the right ventricle, which allows us to pace the right ventricle. So from the perspective of pacing maneuvers, it's very useful to have a catheter there, but it also is a good safety feature If we ever are worried that we're going to cause heart block or injure the conduction system during our manipulations of catheters or during ablation, it's nice to know that we always have control of the rhythm and can maintain adequate cardiac output. And finally, I usually place a high right atrial catheter. In this case, it's sitting in the right atrial appendage. You don't have to have a high RA catheter. Some operators will just put their ablation catheter in the high right atrium during the initial portion of the procedure in order to use it as a pacing catheter. Some will pace from the coronary sinus. There's very different approaches. There's no real right answer. I find that it's helpful to have a right atrial catheter, a dedicated catheter, but in a small child or in someone in whom you're having difficulty with vascular access, certainly this would be the first catheter we would not place. Now, how do we determine, and by the way, stop me if you have any questions as we're moving along. So how do we determine where the pathway is located? We've talked about this previously. There are many different algorithms that are used to localize accessory pathway location when someone is pre-excited. This is the so-called Aruda map, sometimes referred to as the Oklahoma map because Dr. Aruda and Dr. Jackman long-term were in the University of Oklahoma. And so there are 4 steps to this particular algorithm, which I find the easiest one to use. And this is all of these are referring to the axis or the positivity or negativity of the delta wave. So step 1 is to look at lead 1 to see if it's isoelectric or negative, or if V1 is R is greater than S. So let's go to the electrocardiogram. I think we would say that in V1, R is not greater than S. And in lead 1, I think we would agree that the delta wave is 100% positive, suggesting that the answer to that is negative. So then we move on to step 2. Is lead 2, is the axis of the delta wave negative in lead 2? So in lead 2, I think, again, we would agree that the axis of the delta wave is positive. So that's a negative. We always hate it, by the way, when this is true, because it's a very high likelihood of being in the coronary sinus or in the middle cardiac vein. And although the map is very accurate in predicting that, this is one of the single most difficult areas to ablate accessory pathways. We can go over that in the future as to why that is. So now we have negative on 1 and 2. So step 3 is V1 isoelectric or negative. So I think we would say that the delta wave is probably negative or isoelectric, but it's certainly not positive. So we're going to say yes on that. So that puts it in the septal region. And then we're going to look at lead AVF, whether it's positive, isoelectric, or negative. And in lead AVF, I think we would agree that it is largely positive. And so that puts us in this category. Then finally, it's asking us if the QRS axis is greater than 0 or less than 0. And I think you would agree. Oops. With an upright QRS in 1 and in F, it is greater than 0. And so that puts us in the anterior septal region. And the anterior septal region, as you know, is the area near the AV node and the bundle of His towards the most superior aspect of the triangle of Koch. And this map has a very high sensitivity, specificity, and positive predictive value for that. So when we go into a case like this and we see this type of pattern, we know that we are going to be dealing with a potentially difficult to ablate pathway because of its location. And, you know, when I'm seeing patients in the office, I routinely will look at the EKG in order to inform decisions regarding whether or not I'm going to take on an ablation in a particular sized patient. So, for example, if I'm seeing a 10-year-old who is 32 kilos, which is relatively small, and I see anteroseptal pattern on their electrocardiogram, if the patient is not particularly symptomatic, this is a patient in whom I would wait until they grew, in the theory that possibly the distance between the pathway and the specialized conduction system will grow as the patient grows somatically. I don't really think it makes sense, especially in an asymptomatic wolf, to take such a patient to the cath lab when they're little because of the risk that you'd have to back off or even, frankly, cause heart block. So I like to use this to help me, and this is the area, the anterior or the mid-septal region, which carry the highest risk for heart block. And so I am skittish around this area, understandably, and I really don't like to take patients to the lab unless they're either very symptomatic or large. And because usually by the time you're close to adult size, we often can find enough space between the pathway and the conduction system to safely ablate pathways, as you will hopefully see in this case. Is that any questions about this so far? Okay, let's move forward. Thank you. Okay, so this is our EKG. So the next thing we do is we look at our electrograms. So again, we have 4 diagnostic catheters in the patient. Now, whenever you're looking at an electrophysiology tracing, the first thing you always want to do is look at the legend on the left-hand side of the screen. The specific way in which the signals are displayed is specific to the individual electrophysiologist. They are not standard. And so, for example, if you're ever taking your board exam and you're asked to interpret an intracardiac electrogram, it is not likely to be displayed in precisely the order that I have displayed it here on this page, nor are the colors going to be the same. It happens that Barry and I used exactly the same colors because, as I often joke, we are all victims of our training, and these are the colors that were used when we were trained in electrophysiology in Boston. But some labs have a almost religious fanaticism against colors in general and want everything white. Some will use different colors. So the point is, and some will put the His below the CS, the high RA at the bottom. Every place is different. So you have to look at what the signals are. So here we have a catheter in the high right atrium, and we see that we have an atrial electrogram. And how do you know which signal is which? Well, you always look at the 12-lead electrocardiogram, and we see that the atrial electrogram is starting just prior to the onset of the P wave, which makes sense, of course, because in order to have a P wave, you have to depolarize a large enough portion of the atrium to create a P wave. And so we're recording from the high right atrium, presumably very close to the sinus node, and therefore recording a signal that even precedes the onset of the P wave or is coincident with the onset of the P wave. But it's pretty clear, right, that this cannot represent anything to do with the ventricle because the QRS is all the way over here, okay? Now, then we have the His bundle. So we have typically in the His, we have an A, a His, and a V, but we don't actually see an A, His, and V. We sort of see a little A and a big V, and then you could almost imagine that there is possibly a little His in here, but everything is kind of smushed together. So when you have a patient who has WPW and you see that the A, the His, and the V are all sort of squished together as they are here, that's a worrisome finding for the electrophysiologist because it means that the pre-excitation locally is so profound that you almost can't see a His there because you are pre-exciting the ventricle prior to onset of the His bundle. And that is usually an indirect sign that the pathway is at least close to the bundle of His. Okay. Then we go to the coronary sinus catheters, and in our laboratory, we display them from proximal to distal. Notice that we display the His from distal to proximal. So I'm trying to show you that it's very idiosyncratic how people display their signals. But so the proximal CS, remember, is towards the mouth of the coronary sinus. The distal CS is in the left atrium. And the thing that's most jumps out at you is look how much earlier the ventricular electrogram in the His bundle is than the electrograms on the left side. Now, it's usual that the left-sided electrograms will be later than the ventricular electrogram in the His, because even in the absence of WPW, you will be conducting from A to V via the AV node and His-Purkinje system. So we would expect that the earliest ventricular electrogram from standard intracardiac catheters would be near the His. But this, the degree of earliness, the degree of difference between the onset of the V in the His catheter and the onset of V in the proximal CS is pretty significant and suggest. I mean, this is probably well over 150 milliseconds earlier than the onset of the proximal CS, suggesting that there is actually activation of the ventricle very early in the area around the His bundle. And then finally, we have the electrogram from the right ventricle. And this is also interesting to see how the right ventricular signal is so much earlier than any of the CS pairs, including the proximal CS, which is, although in the posterior septum, still relatively close to the AV node. So again, suggesting that there is some kind of eccentric AV conduction, in this case via an accessory pathway or WPW. Does that make sense? Any questions about that? Okay. So the first part of an EP study, when we're doing testing for any patient in whom we're considering doing an ablation, is to pace the atrium. And the goal of pacing the atrium is to do a few things. First of all, when we're talking about a patient with WPW, right, we want to know what is the risk level of the patient's pathway. Remember that for WPW, our biggest concern is the risk of sudden cardiac arrest due to rapidly conducted atrial fibrillation. Now, some operators will routinely induce atrial fibrillation in order to know exactly what the one-to-one conduction is via the accessory pathway in AFib. But a surrogate of that is to atrial pace the patient and create what we call a SPERI, or the shortest pre-excited RR interval. And so we are doing this to assess the pathway's level of risk, which will inform our degree of aggression in trying to get rid of the pathway, right? If you have a pathway, as this one suggests, that is very close to the AV node or the His bundle, obviously the degree of aggression that you're going to show in trying to ablate this will be informed by how dangerous the pathway is. And that will obviously key you into how much risk you should be willing to take. If the patient has a high-risk pathway, we would be more willing to take risk. Obviously, we never want to have heart block in anybody, but sometimes we're forced to take that risk if we have something that we are worried can actually truly cause a sudden cardiac arrest. So we are pacing faster and faster in order to determine what the shortest RR, pre-excited RR interval is. So here we are at cycle length 410, which is a little slower than 150 beats per minute. And first of all, if you just look at the ECG at the top, we see that we are pre-excited, but you can also tell we're pre-excited by continuing to see this very tight AV interval in the His catheter. And what you're seeing here is that the difference between the ventricular electrogram onset in the His and the CS is even greater as we are going faster and faster. And that's because there's decremental conduction in the atrial myocardium to the from the A to the V, but not in the pathway. So as we get faster and faster, the pathway AV time remains the same as all the other conduction intervals lengthens. So here we are at 410 and we're conducting one-to-one. Now we've gone down 10 milliseconds at a time, but here we are at cycle length 310. And we are still conducting via the accessory pathway at 310. Now, remember that the level of real danger is 250 milliseconds. And what we consider to be quote unquote low risk is longer than 300 milliseconds. So we don't know the answer at this point. Here we are, and we are at 280 milliseconds. It says 300, but it's decrementing on the page itself. But here we are at 280 milliseconds, and we are still conducting via the accessory pathway. We still see this very tight AV interval. We still see pre-excitation, and we see how much earlier the ventricular electrogram in the His is than the V electrogram in the coronary sinus. And then as we stay on at 280, what we see here is we are pre-excited, and then we have an A with a very long AV time. And now we see that there is, in fact, a His on all three channels of the His catheter. and we see a narrow QRS. And so basically, we have jumped from the accessory pathway to the AV node. And in the next slide, this is what it looks like on the 12 lead. So we start out pre-excited here, and then we go, actually we have a non-conducted beat, but we're all non-pre-excited at this point. So basically, what we would say in this patient is that the shortest pre-excited RR interval was 280 milliseconds, which would not qualify as high risk, but would also not qualify as low risk. So this testing is helpful, but not very helpful. Okay. Then we do atrial extrastimulus testing. And the goal of this is to figure out what is the effective refractory period of the pathway, which is another indirect marker of risk in people who have WPW. How fast, at what interval will it block? So here we are at 400, 290, and we are still conducting through the accessory pathway. We see very pre-excited beat. At 270, we are still conducting through the accessory pathway. And at 260, finally, we block, and we see clearly that the A, H, and His, there's a very long PR interval with a narrow QRS. So this is actually the accessory pathway effective refractory period, we would say is 400, 260. So again, not the highest risk, but not a low risk pathway either. Now, at this point, one could induce a fib if you are sort of in the middle here, not sure how dangerous this is, because AFib is, we think, the very best way to tell this. But I think that in a patient, this patient, I believe, was having SVT clinically, so there was no question that we weren't going to try at least to ablate this. Now, when we see that we can block so in other words, just so we're all on the same page, the effective refractory period of the pathway is longer than the effective refractory period of the AV node, meaning we can actually do extra stimulus testing and block in the pathway and demonstrate the node. This slide here is a gift to the electrophysiologist. Why is it a gift? Because when we're mapping, we know from this signal here that and from the EKG tracing and the pattern, that this is going to be near the AV node. And so if we are mapping near the AV node, we need to have a way of determining if the catheter and where the pathway is located is sitting on top of the AV node or the His bundle. So by being able to demonstrate conduction through the AV node by taking advantage of a difference in the effective refractory period of the pathway and the node, it means that if we're in a location where we think we're going to be, have a very good signal to ablate, we can do an extra stimulus test in order to block in the pathway and determine if there is a His deflection on the distal end of our ablation catheter. Clearly, if our ablation catheter looked like this when we were mapping, we would say, well, this is not a safe place to ablate because we are actually recording a His signal. And we know that the interval between the P wave, the A, and the His is the AV node. So we would be presumably too close to the AV node. Now, some operators would consider using cryo energy at a location like this on the theory that it's reversible. But the point I'm trying to make is I think in a perfect world, we would not want to ablate anywhere near this. So if I'm mapping and I don't have a difference between them, it's very challenging to know if you're in a safe location. So once we see this, that we can actually block in the pathway and conduct through the node, we know that we will have a much safer case because we will be able to confirm that where we are mapping is either on or not on the His bundle. Okay. And then when we finally get down to 210, we no longer can capture the atrium. And so this is the atrial effective refractory period. Okay. The next thing we do is ventricular extra stimulus testing, which I am not going to review today during this, but the interesting thing here is we're V-pacing, and we gave 12 milligrams of IV adenosine. And Molly, what are you seeing here?
So let's see. We have, and we're set, we're our, oh yeah, you said we're repacing. Okay, sorry.
If you look
So
at the
we're
slide
seeing evidence.
carefully, the answer is there.
Yeah, so we're repacing, and it looks like you've given adenosine, and yeah. So we're seeing block by like, trying to decide which beat. I think by the third beat.
Mm-hmm.
Yeah. And so we're seeing that we're requiring pacing, but we're having VA block with adenosine, meaning that we're not having any conduction like from V to A after giving adenosine through the path, not the pathway, through our AV nerve band.
So let me ask you something. This patient we've clearly see has WPW, right? We have a pathway. Does this surprise you that we have VA block with V pacing and adenosine?
A little bit, because I didn't think that we would expect the adenosine to affect the accessory pathway.
That's exactly right. It's actually quite surprising, right? Most accessory pathways are adenosine insensitive. But this particular pathway, that is not the case. This pathway actually can block with adenosine retrograde. So, just giving you an example of why EP is challenging and endlessly interesting, because although I've told you guys many times that accessory pathways are generally adenosine insensitive, here's a very nice example of one that is not. Okay. So can't use that rule in this case. Okay, so the next step is we now have the pathway. We have seen that it is not low risk. So at this stage, we would typically map the pathway. Now, some people might at this point give the patient isoprel since they're under anesthesia in order to demonstrate how it responds in the setting of a higher adrenergic tone. Literature suggests that about 30% of people, if you give them enough isoprel, rather, you can make the pathway seem about as dangerous as you want it to be by dialing in the dose of isoprel. So there's a lot of debate in the world about how much, how valuable this testing is, particularly in kids under anesthesia. And at some point, I think I'm giving a talk on this to the group on cardiology grand rounds here. But I think the bottom line is somebody who is conducting at a cycle length lower than 300 milliseconds, who is symptomatic, we would usually try to map. Now, when we map patients with WPW, we have many different ways we can map. But in somebody who has a pathway that conducts antegrade, generally speaking, our preferred approach is to map antegrade, and typically we'll do it in sinus rhythm. And the goal is to find a ventricular electrogram on the distal ablation catheter that precedes the onset of the QRS. And what we're looking for essentially is the earliest ventricular electrogram we can find on the tricuspid annulus that precedes the onset of the QRS. But importantly, we want to be sure that we are also not on critical conduction tissue. And so we need to be on the annulus because we believe that pathways are narrowest at the annulus and therefore should require the least amount of radiofrequency energy to ablate them, which is why we always try to ablate on the annulus. You could theoretically ablate in the atrium or the ventricle near the breakout point, but you would probably need a much longer line of ablation and much less likely to be effective. So we're mapping, and I've cut forward quite a bit here, but basically what we're looking for here, if you look in this, we are actually, in this case, we decided to pace the atrium. Sometimes when we're doing a WPW ablation, we will pace the atrium because it causes the pre-excitation to be more obvious. And so the important thing when you're mapping, the first thing I say to Josie when she's doing her mapping is, what are we going to use as the fiducial point? Meaning, what are we going to compare our local ventricular electrogram to on the QRS? And we want to pick a point on the QRS that is very consistent from beat to beat, so that, you know, on one beat, she's not recording from here, and then on another from here. And in this particular lead 1, we have this sort of valley between the P wave and the QRS that seems fairly consistent from beat to beat. And so that was how she mapped this. And generally speaking, you'd like to be a minimum of 20 to 30 milliseconds before the onset of the QRS. You'd even want to be more than that if you could. And you also want the AV time locally to be as tight as possible. And in this case, this is the electrogram on the distal ablation probe. You could make the argument that this essentially looks like one signal, but this is in fact an A and AV that are on top of the pathway and are so close to the pathway that there is in fact no isoelectric period between the atrium and the ventricle. And where this actually, where the A ends and the V starts is challenging to know, but it, as you can see from this measurement, Josie measured it from here to, she's saying that the onset of the atrial electrogram is back here, at least 31 milliseconds before the onset of the QRS. Now, we don't have the luxury in this demonstration today of all of the other sites we looked at, but let's take for the sake of discussion today that this was in fact the earliest site that we looked at every area, and this was the part that really came out the earliest. So now we have to figure, but what I'm not showing you is where the catheter was at this time, but presumably it was right on top of where the His catheter is located. So at this point, we don't know, though, even though this is a very early signal, we don't know if we would get heart block were we to turn radiofrequency or cryo-energy on at this point. And I should tell you that most electrophysiologists in this area would use cryo. But my preference is that if I feel it's safe, I'd rather use RF because it's more efficacious, as long as we believe it to be a safe area. So how do we know if it is in fact, and here again, I'm showing you this signal once again, that the if we assume that the onset of the ventricular electrogram is here, then we're basically saying that we are approximately 30 milliseconds before the onset. So how do I know that that I'm not sitting on the His or on the AV node? Well, we already have shown that if we do an atrial extra stimulus early enough, we can actually block in the pathway and still conduct through the AV node, which is what we do. And so we do an extra stimulus on this beat here. So you see here we are pre-excited. Then we put the extra stimulus in, and we see here that there on the distal ablation probe, there's a clear A and a V. So the first thing to say is this is very important because it shows that when we're seeing, you know, when I told you this was an A and a V together, you kind of had to believe me without really having any proof of it. But now when we block in the pathway temporarily with an extra stimulus beat, we see that in fact there is a fairly sizable atrial and ventricular electrogram here. And so when we're looking at this signal, we are in fact looking at two signals together that are just broken apart when we block in the pathway. So this is an important demonstration, this extra stimulus beat, because it shows us that yes, we are very nicely on the annulus with a good balance between the atrial and ventricular electrogram. Second, we do not see a His deflection here. Notice that there is a His in the His, but when we look in our distal ablation, we don't see any evidence for a His. So that is also somewhat reassuring that we are not in a dangerous location. And there's whole literature on how you can get to this area without, you know, to reduce the chances of getting heart block. We can go over that another time. But the point is, once we see this, we're feeling a little more comfortable and safe with this area in terms of concerns of danger to the node. Because I am a paranoid individual, I would typically ask the person at the stimulator to do this 3 to 5 times to be certain. And I would also make sure that I feel comfortable that I am in an area where I don't have to worry that the catheter is going to move, because obviously even a few millimeters could potentially be dangerous near to the AV node. And so here we are. We turn on radiofrequency energy. Presumably we've done that testing multiple times. And what we see here, if you just look at the 12 lead, or the surface electrocardiogram rather, we see that basically we're less pre-excited, and then on the third paced beat from the time we turn radiofrequency energy on, we have lost pre-excitation. And you notice the difference in the His bundle, how we have now a His and we did not before. Now, the reason that there's no signal on the coronary sinus catheter is because I probably took out the CS and am ablating this patient from the right IJ. And that's just a technique that I prefer to use for this. We've published this and it's been around for a long time. And so if we look at the surface electrocardiogram, we turn on the radiofrequency energy, and basically we're mildly pre-excited on this beat, and then on this beat we are not pre-excited. And so the accessory pathway blocks in about 900 milliseconds, and there are all sorts of studies that show that when you have efficacy with an ablation lesion in less than 2 seconds, the likelihood that you were in the right place and that it is not coming back is very high. And in fact, we see here that in, basically we got it very quickly. And this is the patient's 12 lead following the ablation. And we see now that we are not pre-excited. And very importantly, when we are ablating somebody, in this area, once the pathway goes away, everybody who's looking at the monitor is checking to make sure that this PR interval is not changing, is not getting longer as we ablate. Not only are we worried if it's getting longer, we are also worried if it's getting shorter, because that could be an indication that we are heating the His bundle, and we may not be able to tell that the patient is conducting. So one of the things that I try to do is to pace a little bit faster when we're ablating near the person's AV node, in order that we can confirm that there is AV conduction and that it is stable at all times as we are delivering radiofrequency energy. And in this case, it was, and it resulted in a long-term success. So again, this was the electrocardiogram at the start, and this is us at the end, showing clearly that we have a loss of pre-excitation and a successful ablation. Any questions?
No, thank you so much.
Okay. All right, guys, that was a good case from the distant past. Thank you for making me remember that. Have a great day, and I'll see you at Sinai in just a little bit.
Thank you.
Thank you.